We're giving everybody another minute.
Yeah, we can probably get going now.
I think we can. We got a big crowd.
Yeah, I'll say we got a pretty good attendance so far. So do you want to lead off? You want me to lead off?
I'll just say, I think everybody knew we were thinking we would hold on having meetings this week, and it's clear, it was very clear that we needed to meet. So thank you all for paying attention to your emails and for joining. And I see, thank Mike Mendoza for joining. I think Chad will let you lead off with things, and you and Mike, and then we'll really answer questions and try to fill in the gaps and all the changes.
And Mike, you're you are much more knowledgeable about the state of the world than I am. So do you want to give your tidbit first, and then
Sure.
I can mine?
Yeah, sure. I'll start off by just saying thank you again for all of your work. I know that it's a crazy time and the holidays are upon us, but as luck would have it, everything's sort of coming to a confluence right now. Those of you in the Pittsford School District probably already heard that Pittsford schools will have to close tomorrow. They have a little mini outbreak in exactly the wrong cluster of people, bus and mechanics in the garage. So, I think unfortunately that's not going to be the last that we see. I had my weekly conversation with the school districts yesterday, and it became pretty clear, given how transmissible Omicron is. You all have seen the data. 73% of the new cases last week in the United States are identified as Omicron. Here at the U of R, Dr. Apostolakis has told me that he is not aware officially that Omicron has been isolated in any of the specimens yet, but based on what we're seeing in the health department, based on the rate of reinfections among people who have had a booster already, I believe that Omicron is here. It's just a matter of time. So, and I guess from the healthcare standpoint, the challenge will be that given that this is so transmissible, there are no updated guidelines on how to manage all of this. So for now, I would say just continue as you are, recognizing that I think things are going to have to change. I don't know that we're going to be able to test everybody who comes in wanting a test. We've done everything we can to push test kits out to the community. But I do hope that by January 3rd, when schools are scheduled to open again, that we have new guidance, because, if the guidance remains as it is, I don't see a path toward opening normally. And it's everybody's goal to open normally. I mean, what we're talking about among the health departments is it possible for people to test out of isolation with an antigen? And that's unheard of. But, the question, if Omicron is truly highly contagious, but milder in severity, the question is it reasonable to even consider that? And that's not something that we would have ever uttered a year ago. But the goal is to keep kids in school as safely as we can. But right now, I think there are a lot of unanswered questions. So I wanted to just tune in real quick to hear thoughts, reactions from this group. I'm going to be meeting with my colleagues again later today. I'm meeting with the hospital leaders later on today as well, to see what needs or what can be done. But if you all have input or suggestions, I'm all ears.
Mike, can I just ask a couple of questions, and then folks can chime in? There's some word going around, and I can't find validation one way or the other, that many, if not all, of the antigen tests may be even more insensitive to Omicron. And so
I've heard a lot of varying reports. I haven't seen anything that's particular to the platform that we've shared, either the iHealth, which is the little orange boxes that many of you've gotten, or the Binax Now. I haven't seen anything stating that is true for those. I know that some of the platforms are not as sensitive to Omicron, but it's very manufacturer specific, believe it or not. So when I hear that, hopefully I won't, but if I hear that the iHealth or the Binax are not going to detect Omicron, we'll definitely get that out there, but I haven't seen that officially yet.
Okay. And then also for the monoclonal antibody treatments, that obviously they are in more ration supply, but the efficacy of those may in fact be reduced to Omicron?
Yeah, that I don't know. We should talk to like an actual immunologist about this, but my understanding is that T-cell immunity is what's more helpful against Omicron than antibodies.
Right. Okay, now I'll shut up.
Can I just ask, I'm wondering if it'd be smart, and I know that this might be bad with disparities in access to supplies, but encouraging, pushing a KN95s or a different, a little bit more of a secure mask for the school age population. Just again, thinking about anything we can do to keep kids in school. There's layers to that, I get it, but
Yeah, so
families can do
I'm not sure it's public yet, but by the end of this week, I think we're going to be getting in about 330,000 KN95s. I'm working with my legal team right now to figure out if we can release N95s into the world. N95s are,
Yeah.
medical respirators. Technically, they need to be fit tested and the whole shebang, but I'm looking to see if we can get a waiver to that. But the communication around a well-fitting mask is more important now than ever. The double mask message is probably more important now than ever. I think, unfortunately, the cloth masks are not going to stand so well here. So, but that's a message that is worth getting out, I think.
Okay, I'm supposed to be on Channel 13 tomorrow morning talking about whatever I want to talk about Omicron. So you tell me and I'll put it out there.
Yeah, I think masking with a high quality, well-fitting mask and boosters that you can get your booster and have your protection in 2 or 3 days. It doesn't seem to be a 2-week phenomenon like the second dose of Pfizer or Moderna.
So I'll lead off and I do hope people will unmute. I know that the group tends to be a little quieter than they used to be early on, but I think this is a great opportunity to talk. Mike, I appreciate that you all are doing everything possible to keep schools in session. I mean, we all know how devastating this has been to have kids be remote for all aspects, their education, their development, their behavioral health, their social and emotional health, and what that would be like for families as well. But I just wanted to say, I appreciate that you have been a champion for that and your team has been a champion for that. And I think the additional question I would throw out to the practice teams who are on here and giving Mike your reflections on what's happening is, at the beginning of the pandemic, we instituted what were critical or essential visits in order to, rein in the number of kids coming into the practice or the number of adults coming into a practice for our adult providers. My worry about instituting something about essential visits is that, having contact with these kids, regardless of whether they're coming in for an immunization, is so important. Do we need to build out procedures even more for patients to be able to have access to testing without having to come into the practice because of just the overflow? So I'm going to be quiet and I'm going to ask if anybody out there would like to unmute and give your feedback.
Silence.
It's so hard to know. There's so much that we don't yet know. I guess what I would say is if you hear through your various, academic circles and, pass along anything you hear. I just don't think anybody, neither the schools nor the practices, know what to do with something this contagious. And the question is, our usual question in medicine is, how will this change our management? I think that's the big question that we're still struggling with, right? With regard to testing.
Can we go back to routine testing in school or more aggressive testing in school? I mean, I think, if our layers of protection of masking and distancing are going to continue to work, we got to prove that they're going to continue to work so we can keep kids in schools. And nobody likes it. But again, I mean, I think if the North Star is kids in schools, what are the layers we have to do to do that?
Yeah. I am working with the city to try to implement test to stay. It's going to be a challenge in the city. The schools have, the vast majority of schools, and I believe all public school districts have PCR point of care tests. Again, how do we use that? That's going to be more likely to be positive than an antigen test. Yeah, I'm hoping for guidance. If we want to try to create our own guidance, some kind of a test out of isolation thing, I mean, we'll go completely against the state on that, but I'd rather have a plan than to just wait. But testing out of isolation or shortening isolation to 7 days with the test, those are things I'm willing to consider. And then, of course, there's all the teachers and staff. We got to keep them,
Can you
well,
partner with a certain district or a school? Or I'm thinking like some of the private schools that are smaller, they've still had some cases, they haven't had as many, but I'm just thinking like to get data on, does that actually work? How many do we need to test to say that that's feasible?
yeah.
Because some places are clearly more willing to test than others.
Right.
So I think there's a good question that just came up in the chat. So let's talk about home testing for a minute and the limitations around home testing. So one of the questions that came up is it reasonable if families took a picture of the home negative test? And if that is a way, because what the tricky thing is right now, if the home tests aren't being honored, then somebody has to go someplace else then to get the test. So Mike, some of our practices have said they'll have a family come to them. Could they have a family come to them with their home test, do the test there, and they verify it? That's again another layer of bringing in a symptomatic child who probably doesn't need to be in a practice to have somebody view their test. So are there some streamlining of processes there that could help? I don't know.
We hadn't been open to that, largely because the schools had said, how do we verify that? And I said, you really have to trust the parent. And honestly, a lot of the schools said their legal counsel advised against accepting those because the schools would accept liability. But honestly, it's a new game. If we can find a way to split the difference here and accept negatives, I'm open to it. But right now, it's not something that the schools want. And it's certainly not something my team is comfortable with. But, as the game changes, I think we have to revisit all of this.
Don't some of the tests have those QR codes that allows for like some kind of app official tracking? I mean, I don't know if people would agree to that, but.
Right, I think they do. I'm looking at the iHealth one now. I believe there is one for this. And then I know the Binax has some kind of a
It definitely
platform.
does.
It's going to be a digital divide access kind of issue, but I'm open to that too.
It sounds like we're definitely at the something is better than nothing,
Yeah, that's how I feel.
unfortunately.
So Mike, I mean, just from a logistical standpoint, and this gets to Whitney's question. I mean, we know from the South African data, it does appear that the severity of illness is less. There was, I think it was JAMA or one of the articles that came out Monday that basically said, well, that doesn't necessarily seem to be reflecting in some of the early experience in the US, that the severity maybe not on par with Delta, but certainly not, sniffles and everybody's fine kind of situation. So at what point, and is this even an answerable question, do we say, look, and I realize I'm saying this and I'm going to sound kind of quasi going a completely different direction, but do we say, look, the transmissibility is going to be so high that we're now in kind of a flu season situation where we say, look, if you're actively febrile, you stay home, but otherwise it's so prevalent in the community that you can't possibly avoid spread. And so between hospital staffs being decimated and, all of our hospitals are the #1 employer in the region. So if their kids are home from school, then that means they're home from work. And at some point we just have to say, we do have to transition into a live with this kind of mentality. And we no longer can take a prevent and protect approach.
Yeah, no, the prevent and protect, we all in the health departments have begun the conversations of discontinuing contact tracing and case interviewing. The traditional way of doing case interviewing is akin, the way the state health commissioner, who by the way is boosted and got COVID, the way she put it was, case interviewing and tracing is like stomping out embers when your house is on fire. Right. So there's just no, and my team feels it. We're calling people and it's like, 2 days later and we're not making a difference in transmission at this point. But, until the CDC or the state says you can discontinue case investigation, I don't think we're in that position to do it, but we're certainly, considering it. I think Omicron, I've heard a number of experts say that Omicron is the first variant that tests our country's ability to quote live with it. This will be highly prevalent, quasi-endemic at some level. And yes, we're going to have to figure out how to live with it, going back to the usual, if you're febrile and vomiting, you got to stay home, but otherwise you can come in. That's the kind of thing that I think we need to get to. because otherwise there's no way that we're not going to close down schools. So, and you know, unrelated or related, all the higher ed institutions are debating about having their kids come back, testing everybody on return. What is that going to do? I mean, if you test everybody on return, you know, 70% of them might be positive. And what do you do with that? So it's a very different ballgame right now.
Right.
So Mike, just taking, and Chad, both of you, just taking a giant step backwards, because I think we sort of launched right into talking about Omicron, and I think people may be at different stages in terms of what they know and what they've read. There's a question in the chat about, you know, we know about the increased contagiousness or ease of spread, but what about severity of infection? So I wonder if we could just speak to that briefly and then kind of move back to where the conversation is.
So a lot of the data that we're getting, and it's really observational data, are coming out of Africa, South Africa, the areas that have had, to our knowledge, Omicron for longer. I have not read a report that says that Omicron is more severe than Delta. Everything that I've read is either as severe or less severe than Delta. And so the question really is there something unique to the United States population and our level of immunity and, you know, balance of natural versus vaccine immunity that makes us different? You know, highly vaccinated communities in Europe got Omicron and did relatively well from the severity standpoint. But their hospitals, as you know, are getting overwhelmed. So, you know, that's what I know about the severity of Omicron. I don't know if anybody else has more recent knowledge though.
I'm trying to find the article now as we speak, but I thought it was in JAMA, but it's not coming up. That basically said the early experience, I think it was out of New York City, was that the severity was less than, but not as low as what was being experienced in South Africa. And the skew was that the South African data was in a highly vaccinated, much younger population than what we're typically seeing, especially they're coming to our hospitals. Now, granted, how much Omicron is there that's not coming to our hospitals? There's probably a lot more in our community that we're not seeing there, but at least among the hospitalized population, they were younger and less affected, whereas we're older and more affected.
Yeah, I saw that. You know, I think as far as action steps go, you know, if you look at the booster rate for 65 and older, I think it was as of last week, it was only 40%. So we got a lot of people to boost in that vulnerable group. And, you know, among, I think the 18 to, you know, 55 or 18 to 65 group, it was, you know, 30% or something. So, and that was last week. I just came from our Fleet Center booster clinic, and it was a madhouse. People are coming in to get their boosters like it's, you know, a TV on Black Friday.
That's good.
Except we're not giving out TVs.
That's a tough image to
Yeah.
have in my head. I hope people are behaving.
Analogy.
As an example, I mean, I will say, if you look at the last 7-day rolling average, we were 20s or less for a while. We got up to 40s and we're like, okay, we're starting to experience a little bit of a surge. Now we're pretty much in the surrounding Monroe County, surrounding counties in the 50 to 60 per 100,000. But if you go to Tompkins is 259 per 100,000 just in the last 7 days. So Thompson and Schuyler have shot off the map.
Is that Cornell?
That's Cornell.
Yeah,
Cornell.
Cornell.
Tompkins is skewed because of Cornell. They've traditionally been among the best
Mhm.
in the state. I'll point out that our cases per 100,000, I think we're lower than Onondaga, and we've been lower than Erie for a while. But our hospitalization rate per 100,000 has been consistently higher. And you know, I've got both hospital systems thinking about that. I mean, we have an older demographic in Monroe County, and the feeling is that, you know, when you're in the middle, people from Onondaga come here and people from Erie come here. So we may be attracting more of a regional hospitalization pool than even Erie and upstate. So, but yeah, that is a concern for us for sure.
So linking the conversation about hospitalization and severity of disease and immunization, can you speak, or Chad, you want to speak a little bit to at least what we hear from URMC about in terms of and what you're seeing in terms of hospitalized patients and how many are vaccinated versus unvaccinated. So again, severity of disease when you're vaccinated. And that ties to the question that Bill Meeker just put in the chat, which is that he really is getting a lot of pushback now about the booster, people saying if they're going to get Omicron anyways, why vaccinate? And so messaging there. So Chad, I wonder if you want to go first, speaking about the hospitals. Elizabeth, I'm sure you got some, I think you posted as I was talking something in the chat too.
Yeah, and I mean, I will say what's interesting is we were about 60-40. As far as 60% of the hospitalized population was unvaccinated, 40% was vaccinated. Now we're at about 75-25 or even 80-20 in some of the hospitals, is the unvaccinated being the higher proportion. And if you look, and of those who are vaccinated, who are admitted, disproportionately are not boosted. So I'm only aware of maybe a handful right now that are boosted and hospitalized. And if you look at the ICUs, both the severity, the number of patients who are hospitalized, that are the percentage of COVID patients who are hospitalized that are in ICU or ventilated, has actually gone up from the same time last year.
Yeah.
So the severity of illness seems to be getting worse as a whole amongst those who are getting hospitalized. So it definitely appears the unvaccinated are the most affected. The vaccinated but not boosted are of the vaccinated who get hospitalized are that group. And then those who are boosted, at least at this moment, still seem to be the exception to the hospitalization rule.
Yeah, that's what I
And
said.
to add to that, I think, Elizabeth, you can back me up on this, but we are not seeing a slew of kids in the hospital hospitalized with COVID. We are not seeing that.
All the other germs, but not so many.
Yeah, not at this point yet.
We had more in the recent past, but this week and last week, it's not as bad for hospitalized patients, for kids.
So I apologize. I just got called to another meeting. So please continue the conversation, and LJ, Elizabeth,
Yep.
let me know if there's anything I need to think about.
We'll follow up with you afterwards, Mike. We'll let you know if other comments and thoughts are shared by the team.
Great. Thank you all.
Thanks for joining.
Sure.
Happy holidays all.
Take
Thank
care.
you, Mike.
So just a couple other tidbits that I can kind of share, just statistics, or other interesting information. So most of you probably know better than me that the Pfizer data came out that showed in 2 to 5-year-olds that a 2-dose vaccine strategy was not successful. They're now considering a 3-dose vaccine strategy. So that, increases the likelihood that we would see spreads and outbreaks in, especially with Omicron and transmissibility in daycare centers and that kind of thing. So that's obviously a concern. The other part is, I think it's Europe, maybe Germany, that has already announced that they're going to go to a 4-dose vaccine series for 60 and older. So basically a 2-booster plan. And the thought is that the United States will likely pursue a similar course in the not too distant future, just because of we know with the 2-dose vaccine plan before that older crowd had a waning immunity faster than the younger crowd. Hence the reason of, for immunosuppressed and the older that they got their dose option even before boosters came available. So now it would be a double vaccine, double booster potential for that older. And although it has not been specifically mentioned, I've got to imagine the immunocompromised would fall into that category as well. So that's obviously a discussion. I did hear, and I don't know, LJ, Elizabeth, you guys may know better than me, that there was some conversation about accelerating the timeline to getting boosters for the kids, essentially. I know we're talking 16 to 18 already, but
You mean the 12 and up?
the 12 and up sooner.
Yeah, I know there's conversation, have not heard anything definitive yet. We're certainly hopeful that will come through soon.
Yeah. So
It just
that
makes sense.
would make a big difference. We're seeing the Defense Production Act being used. The federal government, as everyone probably knows, announced that they were going to be releasing another 500 million antigen kits into the community, and that there were ways that you were going to be able to request them online, but they won't actually be hitting hands until January. So we got a couple of weeks that we're going to have to get through at least before those become readily available. And then the next big conversation is really around shortages in remdesivir, monoclonal antibodies, and then now already the conversation about the availability of the new antiviral drugs for COVID and what the availability and dissemination of those are going to be. So all of that, is kind of all coalescing right at the same time that we're seeing this increase. The big question here locally is the estimate is that probably at least 20% of the cases in the Finger Lakes region are Omicron positive. We just haven't gotten the data back. Our variant subtyping lags 1 week behind. So the data that we get that was actually supposed to come out this morning, I believe, is about positivities that we sent for subtyping a week ago. So we're always going to be about 7 days behind in our subtype analysis, but we know that the rest of the country, Omicron is the predominant. We know that we were lagging a little bit, even when other areas were starting to see a surge in Omicron, New York City in particular. We know that New York City and New Jersey, once again, are kind of Omicron central at the moment, where almost all of the cases are Omicron positive at this point in time. But fortunately, we're not seeing those hospitals being overrun at the same rate that we are our own hospitals. So I can tell you that as of right now, for the Finger Lakes region, the closest ICU bed is in Chambersburg, Pennsylvania, as of 43 minutes ago. So it's definitely getting to be a stress for that sicker population, which is becoming the higher preponderance. I think all of us for the hospitals are looking at, almost all of us are boarding ICU patients somewhere outside of the ICU proper. Especially in the smaller hospitals, we're boarding in EDs and or PACU. One of the active conversations is how far away are we from pivoting to stopping elective cases and using our anesthesia and OR teams as makeshift ICU teams, because the need for ICU is going up fairly dramatically. And we expect that the Christmas holiday coming upon us is going to accelerate that even more, especially with Omicron likely starting to spread like wildfire in our community. So I anticipate the next week or two, we're going to see elective cases go on pause, would be my guess, if I had to guess at this moment. We've certainly not had any we're all trying to keep that afloat as much as possible, because we know that had adverse consequences before, but there just isn't enough ICU nursing staff to go around. The Biden administration releasing 1,000 medical professionals from the military certainly will help, but and I think, right now the Finger Lakes region would be an area that's probably as hard hit as just about anybody as far as staffing needs. But even 1,000 people, those folks get gobbled up very quickly when you're talking about across the entire nation and what they can provide. And it doesn't mean that that's 1,000 ICU nurses and providers. So, that's a skill set unto itself. So I think that's going to be the thing we're going to be hearing about is increased incidence rates. What does this mean for going back to school? What are approaches to boosters? We know that the communities that have been vaccine hesitant are also booster hesitant. And then what are we going to see as far as ICU capacities? Because I think we could probably accommodate the med surge, get treated, go home. But as monoclonal antibodies become less available, potentially remdesivir has shortages, and we're seeing this unvaccinated group potentially get hospitalized at a higher rate and maybe need higher level of care at a higher rate. I think it's going to be the ICU taxing that's going to be the next big discussion in the next couple of weeks. It already is, but it's going to get to a critical point very shortly. And we're going to get back to ventilator shortages and those kind of concerns very quickly. So I think that's the state of the union, unfortunately, at the moment.
Can I make a plea, Chad, to take to hospital leadership that talking about bed capacity in what our normal capacity is versus what we're experiencing now, I think would be so helpful. All that surge stuff, the first go around was so confusing. And so the other day, when they put out the numbers saying Unity has 31 of 31 ICU beds full, and they went through the list. Well, Unity is a 20-bed ICU that has flexed up to have an additional team so that they're covering the 31 ICU level patients. It's not that they're beyond. And so I just think we need to make sure the public understands that we are way beyond and using those numbers. Now, that does not mean that people will not get care. The hospitals are flexing, but just we have to give people a consistent, clear understanding. And these flex numbers just are so confusing. It would be so helpful for the messaging.
Yeah, I agree, and I'll be fully transparent. I think one of the hard things is that it's almost a catch-22. So, if you hit that magic 90 or 95% threshold of bed availability, and you're publicizing that, then all of a sudden the state comes in and starts mandating you can't do this, you have to repurpose that. And for many of us, we're trying to kind of keep that flexibility to provide the care that everybody needs. So it's not that we're trying to game the system, but I think we're all mindful of the fact that right now we're still able to largely accommodate the needs. Granted, like today, we're transferring ICU patients to Chambersburg, Pennsylvania, but I suspect within the next week, we're just going to exceed even that surge capacity, and we're going to have no choice. And then, I think to your point, then it's going to be kind of an all hands on deck, and it probably will need to be publicized much more readily. Not that that seems to change opinion or activity that much, sadly.
Liz, I think we can advocate in our different lanes for that, up through GCH as well, and onto leadership. I think it's really important, clarity of the messaging and understandability, because that could actually change people's behavior. Those are the messages that need to get really loud right now. So I heard a number of things, and I still want to give time for people to talk. I'm just assuming people are multitasking, or they're just sort of overwhelmed with not even knowing what to say with where we are. So vaccination, right? Booster and get vaccinated. Those have to be our key messages. And I hope that what was said earlier helped, Phil and others with this. How do you convey this messaging? Relaying information about what the severity of disease is like in someone who's unvaccinated. And those are the people who are in the hospital. Those are the people in the ICU. That has to be communicated. Thinking about our resources that we have available to us now in terms of vaccination and in terms of testing. We know the practices are all doing what they can do in those spaces and have been doing a great job. I'm just sticking in the chat right now. As a reminder, this is PED specific, but GCH has centralized resources now for PCR testing that is available. There's a link, so families can go to the link if they have a child who does need a PCR test. This is not antigen testing at this point; it's PCR. But if that helps to keep some less ill kids out of your office, particularly as we're getting ready to go back to school. And then the other thing is that the pediatric 5 to 11 vaccination clinic that's being operated by GCH over at URMC down at the medical school end of the hospital is open and has an open link for people to schedule to, if that helps your teams. If we do see a sudden burst of interest for people in getting their 5 to 11-year-olds vaccinated. I think it would be really helpful if anybody is willing to put in the chat or mute what you are experiencing in your practice right now, where you are feeling most, what are the pain points, and so that we can be mindful of how we can support and flex for you all.
There are a couple questions in the chat about, can we accept home negative tests if they take a picture or like a phone video and that's time stamped and send it in. I know we've talked about that at various times about ways to try to. It hasn't been accepted as of yet. I don't know, LJ, if you have any more information on that.
Ugh. I think that was Mike in that space was saying that they might consider that. They're at this point in time, the state guidance says no home testing is acceptable in terms of a negative, in terms of any kind of home testing, except if you have a positive, like a positive stands, you can reverse it with a PCR, if you get it within 48 hours. Yeah, but the issue is rapid antigen testing itself is now part of the state guidance. It's part of at least Monroe County guidance. And this is where it gets really confusing. We have a call out to, an email request for the last 48 hours out to the surrounding counties for them to clarify what they are accepting. And we will share that with you as soon as we get it back. There's a group that is coalescing that information because it's really hard. Many of you care for children who are in Monroe County and outside of Monroe County. And if the processes are all different, you don't know, you can't really advise families. But speaking to Monroe County, rapid antigen testing is acceptable, except in a case where there has been a known exposure. And if you look at we sent out all of the new guidance last week and it's on the AHP website. If there's a case of close contact exposure, the county had been or has been up until this point still requiring PCR because that is such a much higher predictor for transmission and for infection. Where we're going to look like in a week from now, based on what Dr. Mendoza was saying at the beginning of this call, I don't know. I don't know what any of those algorithms are going to look like before we go back to school with kids. So I think stay tuned. Clearly, we're going to want to be reaching out with you all next week, and we may be wanting to have a special session even right before the kids go back into school, just to be able to have clarity around that. I think we're all going to have to be, once again, thoughtful and flexible in trying to do what's best for children and families. The difference between adults and children, the question was asked about antigen and PCR. You know, I think that it's not a difference. The guidelines are really enforced in schools, right? So that's the difference where kids are. But I think when you talk to experts right now who understand these tests, the antigen test remains a concern because of its reduced sensitivity. And we don't know how any tests are going to perform fully against Omicron, although it appears that right now, it appears that the PCR platforms are performing well based on information from other communities. And it appears like the couple of antigen tests that Mike referred to, right? The Abbott Binax now and the iHealth home, right? iHealth test are probably the two. So some of you have reached out and asked, what should we be? If we get test kits for our office that are rapid antigen, what should we look at? Those appear to be the two that are like in use and appear to have the most data behind them. But again, we're going to have to see how they perform against if they're really good at detecting Omicron. But the FDA, Gina, I wonder if you could put the connection, the link in the chat. There is a site that's maintained by the FDA that looks at this actively, and we're going to make sure this is in the messaging that goes out today. But this is something you go on to look at all of the testing platforms and how they're performing, and they really are keeping that up to date. So we wanted to offer that as a reference. I think it just really, the next week is going to remain to be seen what we say. Right now, PCR is more reliable, but accessibility is a different thing. So I'm seeing another note in the chat. I'm just reading. Chad, take over talking.
Yeah, so I think the testing platforms, sadly, we have started seeing, I can say I've seen it myself. So if you go into any of the Walgreens, that kind of thing, you'll see the Binax Now displays are pretty much just rated. They're empty. But they'll have a few behind the counter. And one of them, I wish I'd kept the picture. Somebody actually sent it to me. The sensitivity was horrendous, like 60% sensitivity. And it was like $49 that somebody had paid for this thing. So I think they're getting these, what I'll call off-brand alternatives that are being sold. And I think people are so desperate to kind of have testing to try to get back to school, get back to work, whatever the case may be, that they're going out and buying these things, and they're really pretty bad in some cases. So that's not to say all antigen testing, but there are definitely platforms out there that are insensitive to Omicron in specific and relatively insensitive at best. So just be aware of that.
Sarah Letty put a really important message in the chat about boosting college kids or home on vacation. Really, really good point, because the vast majority of them they got their vaccine and they went off to college. They got their primary series. So in terms of, vaccination in your practices, absolutely. But if you're trying to, increase access or refer families other places, the county sites that are being run are actually pivoting to have more and more opening for boosters. They're actually scaling back a little bit on the kids 5 to 11 because there isn't the demand. They have the ability to flex back and forth, but right now they are really putting all resources in the booster category. So you can refer. Kim, do you want to add to that?
I was just going to say, I know they did over 800 boosters at the Pittsford location yesterday. So people are just flocking to these sites to get boosted.
Good. That's good. Okay. So here's the other thing, just to think about, we're talking about vaccination, and I don't know what the status is within your own practices. But I think, there's been hesitancy about getting vaccinated within the healthcare systems, right? Within our practice teams, within the hospital teams, healthcare providers as well as staff. I think this would be a really important time in your own practices and in your own sphere of influence to encourage people to get vaccinated and so make sure they have the data. Many of you had great rates, and you have not been accountable to the same mandates. And many of you have had great rates of immunization, but I just think like this messaging needs to definitely be shared with all of your teams and with all of your contacts. And I think we're already seeing a definite shift with more healthcare teams getting vaccinated who had been hesitant to do so before as a result of this. So we're at 12:57. Any other last minute comments in the chat? Any other? Liz, you came on initially to give us like the latest vaccine disinformation. You want to give 2 good words or 2 bad words and then 1 good word?
Well, yeah, I mean, so I'm just kind of really figuring out the messaging on this. I mean, the things going around right now, again, are attacking parents who vaccinate children, all sorts of misinformation about that. There is a study that was done this is hot off the press from last night, a study done back in May. That was very well done study looking at, duration of immunity after disease. And at that time, it looked pretty good. The authors are very clear that they do not say this means don't get vaccinated. Quite the contrary, they all fully support vaccination. However, Dr. McCullough, who people know is one of the disinformation does, and one of the leaders of disinformation, has written an article about this where he doesn't mention the day, how old the study is and whatever. And so that's being used to say natural immunity is just as good. The authors of the study have come out very acute in attack mode to say this is completely wrong. You are misrepresenting our data, but that is making the circle. So there's going to be another big push for people to say natural immunity is better. And I can see it right now because they're going to say, because people are getting sick with Omicron anyway, so it doesn't even matter. But I think, if it's all about layers, right? There is no one quick fix. We all want there to be something perfect, and there is nothing. And so we just have to do layers, and it's all about risk mitigation. And so it's lessening the risk. It's not foolproof against disease. It's lessening the risk, putting odds in our favor. And that's kind of always what we do as parents taking care of kids. We always make decisions to put the odds in favor of safety. And that's what boosters are. And that's what masking is. And I think we want to continue to tip the scales, tip the odds in favor of safety. And I think that's what I'm going to go with for the messaging.
Thank you. And again, reminding people to use the terminology when you're talking about immunity that Dr. Murray coached us on. It's disease acquired immunity, not natural immunity, is a really good point. Chad, you got any last words for the team? And what do you want to say about next week? Just for planning.
Next week, I think if there's something new to share, I mean, obviously there's going to be some changes. If there's something new to share, obviously we will reconvene this meeting. Certainly if we have some updates on, back to school discussions, knowing that unfortunately this is going to be a brief school break year, which probably doesn't serve us well in this particular setting. But I suspect there's going to be a lot of evolution in these next few days, and we probably will just begin seeing the post-Christmas effects by the time of our call next week. So if there's something to share, obviously we'll reconvene. Otherwise, I know, hopefully folks are going to get some time off or just want to disconnect a little bit, and we want to be respectful of that. And obviously no one's required to be here. So in the meantime, I would say wrap yourself in cellophane, stay 100 yards away from everybody for Christmas, and celebrate from afar. Trust no one.
Oh my God, I wish I could say something. You're making me laugh. I don't have anything else to say. We appreciate you all. Send your emails. We will continue to try to be as responsive as possible with what information we have, and let us know what you're seeing, what you're experiencing.
Have a great holiday.
Take care, everybody.
See you soon.